If you push your green button,
Oh, yeah, sorry. Make sure your mic is on.
yeah, if you push the button, it'll turn green.
Perfect.
There we go.
Thank you.
Much better. So wanted to acknowledge Rob Dobry for his work on the Montezuma County Hospital District Board over the last several years. He's just finished up a term, and the board relations between MCHD and SHS have just been wonderful over the last couple of years, in part to Rob's leadership there. So thank you, Rob.
Thank you.
So tonight, I'm going to start us with just a brief mission moment. Over the last year, our board has been starting all of its meeting, and many of our internal meetings we start by reflecting on some of the impacts we're having out in the broader community. Sometimes it's an individual patient story, and today I want to highlight the impact of our food and nutrition services. So recently, there was an article published in the journal that you can read a little bit more about, but Karen Hubley oversees our food and nutrition services. And most of us think of that as two things. One, if we're working, we come in and have lunch, and we have a wonderful lunch served in our cafeteria. And if you happen to be spending a night at the hospital, we have a wonderful staff that'll come and take a food order and deliver that to your room. But what's not as visible is a lot of the things that happen behind and around the scenes. So just some really simple examples of the bigger impact that this group has. We have a zero waste kitchen, so all of the food items that come in go out in some way, shape, or form. We actually inventory pre-prepared meals and make sure that if they're not consumed a day or two before they would naturally be set to expire, that they're donated somewhere else out into the community and can be consumed somewhere else rather than risk going to waste. Food scraps are collected daily, and a number of our employees who have farms or ranches or things like that gather those food scraps and take them. And so some of the pork that comes from some of the local farms and ranches consume some of the food scraps that are produced in our kitchen. Outside of our walls, this group also worked really closely with one of the local nonprofits, and several years ago arranged to have a commercial grade milk dispenser placed in their facility. And the group really wanted to increase some of the nutrition for their clients and services, and then arranged with our purchasing group to every month make a donation of milk to go inside that unit. And so for several years now, we've been serving that group in the community, and in large part due to Karen's leadership. And then many of the staff throughout the year will volunteer their time in community organizations, a lot of times 4-H and elsewhere, where there's food competitions or other things, and act as judges or other ways. And so really wanted to start the evening by acknowledging some of the great work that happens through our food and nutrition service. So the things that I'll try and cover tonight in the time we have, and please interrupt if you have questions or there's other things that you want me to expand upon. I'm going to reach back into 2024, let you know a little bit about what we accomplished in the year, talk about what we've got going on this year in 2025, and then some of the challenges that are facing healthcare, especially in rural communities. So a couple of things. We invited a number of new providers to start in the community, just highlighting 4 of the primary care physicians that started sometime in 2024. So 2 family medicine OB physicians, Dr. Megan Viquez and Dr. Carrie Bernard, family medicine physician who's a DO, so osteopathic trained, can do some of that work, Jameson Lobb. And then Jocelyn Hirschman joined us actually late last spring, came from Indian Health Services, has been a resident of Mancos for a number of years, but had been commuting out of the area to work for IHS, and was really excited to come and serve the community that she's lived in and been a part of. And then we've also had a complete board. So just so you can see the current board members at Southwest Health System, it's really a great diverse group of community members. I won't give you all of their bios, but we have some folks with finance background, 2 physicians, an attorney, an engineer, and a community member with a lot of work in both education and healthcare. So great diverse board. It's a pleasure reporting and working with them. So looking at 2024, one of the ways that we were kind of measuring and planning for the year was to look at where we expected to see increases in care over 2023 and where those changes actually occurred. So on this graph, you can see at the bottom a number of different services that we provide. On the left, it starts with births, and on the right-hand side, some clinic specialty visits. The darker bar, the blue bar, is the percentage increase that we had planned for the year, and you can see that in many areas we planned for an increase. Happy to talk about the planned decrease in specialty. It's more of a measurement function than an actual decrease. And then the beige bar is the year-to-date actual, and plans don't always come to fruition. You can see some areas where what we had planned for was busier and other areas where it was less busy. What's circled in the middle is a measurement for hospitals and healthcare called adjusted patient days. And that's a single number that takes into account all of the activity that's occurring both inside the hospital and around the hospital. And what you'll see is we plan for the hospital to be about 5% busier in 2024 than it was in 2023. And when you net all of the activities, we really landed right where we planned for. And that translated into some financial performance as well, which I'll show you in a moment. The other piece that we measure is a number of things, both around quality and the patient's experience. There's a standardized survey that goes out to patients that spend a night in the hospital. So not every service we provide, but those are admitted as an inpatient. And one of the questions that patients are asked is, would you recommend this hospital to a friend or family member? And the same survey is administered to patients of every hospital across the country. And so regardless of size, regardless of designation, whether it's an urban or a rural community, it's the same question that patients have an opportunity to respond to and answer. And each of those bars represents the percentile rank of Southwest health system relative to all other hospitals in the United States. And so I think of this as basketball teams. When I was in middle school, you'd line up the shortest to the tallest. The tallest would be the 100th percentile, the shortest would be the 0, and then there's everything in between. And each measurement is a quarter. The survey's results are produced on a quarterly basis. And you can see that over late 2023 and through 2024, our hospital has been well above the average hospital in the country, and in many quarters in the top quarter, and even a few quarters in the top 10th percentile of all hospitals in the country. And the reason for me this is really meaningful is if somebody comes in and receives care in our hospital and when they leave, they're willing to recommend the hospital to a friend or family member, that means that they received good care and that we treated them well as a person. And so there's a number of things that we measure, but this is one that means a lot to me when I think about how are we doing for the people we serve. On a capital expense side, one of the ways that we transitioned from 2 years ago, almost closing a service, to where we are today, was to really slim down on our investment in capital expenses. So when we budgeted for 2024, we had a planned capital expense of $200,000. To give you a sense of how that compares to our need right now, excluding building maintenance projects, is about $3.5 to $4 million, and that's just over the next few years. And we actually spent just under $50,000 last year. We put into service more items. You can see the items that we put into service, both through the great work of our foundation and doing some philanthropic work and the generosity of people in our community, and also some grant funding. We were able to purchase some other equipment throughout the year, but in total it still pales in comparison to what the need is to replace and upgrade equipment in the years ahead. This is a summary of outside funding that came in. Again, I'm not going to enumerate everything, but you can see there the total outside funding for the year was just north of $200,000. So that's in part what added to some of those capital equipment purchases. And again, a lot of that was philanthropic giving from our community. Our employee retention rates have continued to improve over the last year. So the bars, each bar represents the number of separations in any given month, and the line that's going across the graph that is increasing over the last year and a half is the rolling 12 retention rate, so the percentage of employees that have been retained in the last 12 months. And when we ended the year, or early this year, our retention rate was near 80%. It dropped just a little bit in the last couple of months, but overall is still in a really healthy place. We just got some data that benchmarks us against other hospitals across the country that are surveyed around retention rates, and we're falling just above average. So in the healthcare industry, we've had some tailwinds in terms of employees staying in healthcare and relying a little bit less on contract labor, and certainly we've benefited from that, but our growth in retention has exceeded the growth in retention of the average across the country. So something we're paying attention to as well. So when you take all that activity, the patients we've cared for, taking good care of our employees, and delivering great care when people need it, it's really translated into change in financial performance. So this is looking at our losses and gains from operations. It excludes the sales tax that comes in through the hospital district. So it's really, are we able to generate revenues above our expenses before any of the non-operating income that comes in? There's a few non-operating expenses, but they're really de minimis. And you can see in the 3 years prior to 2024, each year we were losing in the neighborhood of $1 to $4 million just on operations. And last year we finished the year, we just finished up our audit, and so these are audited financials with a net operating income of $1.7 million. That also is translated onto days cash on hand. So again, you may recall going back several years that our relationship with our lenders for the bond has been tenuous. That relationship, as a result of our finances, but really in a good credit to the two boards working together, has improved tremendously. We've been accumulating cash. We're not in the business of accumulating cash for the purpose of having it in the bank. So we do have some plans to invest that both in capital equipment this year and making some transitions for our electronic health record system and our clinics to unify it with the hospital. And then there's some payables back that we have in here as well. But overall, really positive trend with our cash. Even if we spent all of the money that's accumulated for some of the building infrastructure, we would still have more than enough to satisfy the lender requirements and do some of the planning that we have for the future. So talking about what's coming up this year, one of the things we did in 2024 was pull our board together, our medical staff and our leadership, and really start looking farther out into the future. And the horizon that we started planning for was the next 1 to 3 years. One of the first things we did was really to identify what are the core things that we do and for whom do we do those things. And as a result, the board approved a very high-level objectives policy for the hospital. It's not a mission statement or a vision statement, but it really is the direction that I have from the board at the highest level of how to operate the hospital and what things I should be working to achieve. And really the statement says that we have two groups of people that we serve. It's the residents of people in our service area or people that are part of the community we serve, and our role is to improve the health of those people. It's not to wait for someone to show up at our door and be sick or be ill or be in an accident, but our role is really to start thinking about if you are a member of our community, what's our role in helping you live the healthiest life that you can. And the second group of people are any of us that may part of the community, but also acknowledges we have people that are coming to visit for a lot of reasons, tourists to visit, friends or family, and then there's a lot of commercial transportation that happens through this corridor. And so in addition to thinking about people's health, we need to be available and accessible for urgent and emergency conditions. And again, that's a broader group of people we serve in that regard. And then the other place that our board gave us direction is where should you expect to gain revenues. And so you'll notice opening a lemonade stand or something like that is not on the list. And we have 4 sources of revenue that we expect to draw from. One is the fees that we receive when we serve patients. The second is the philanthropic activity from our foundation. The third might be any grants or awards that we receive. And the last is the sales tax and the property tax that flows through the district and that contributes to our ability to operate. So with that in mind, we started doing some planning, and our planning really centered around the idea that if we take care of the people inside the organization and provide the right environment for our own employees and serve them well, that we will have a safe and high quality environment so that when people come in to receive care, they can rely upon us to have, again, safe and high quality care. And if we do those things right and do them well, we will naturally grow. People will want to come and receive care in our hospital, and that will allow a virtuous cycle that allows all of us to have access to world-class care to home, close to home. So that's the premise on which we started our planning. I won't go through all of the pieces that are on here, but in the next couple of years, they really fall into a few areas that revolve around employee retention and shifting a culture towards one of high reliability and building the skills and knowledge around that. We expect that patients are going to receive timely preventative care. And so again, we're really starting to build some infrastructure, and I'll talk about a little bit of that tonight around how we're impacting patients in between their visits to the hospital. And we also want to achieve national recognition for both safety and quality. Internally, we have a lot of information and we know that we provide great care, but we want those who are not in our walls every day to have a way to know that that's true. And then on the growth side, some of the work we're doing is around access to primary care. We want to increase the utilization of existing services. I'll touch on that in a moment, and then increase availability to specialty care. The reason that middle bullet point is really important for us in terms of increasing utilization of existing services is generally it's not going to require us to purchase new equipment or attract new staff with skills or experiences that we don't have today. And so if we can utilize services that we have more or increase that utilization, most of the new revenue that comes from patient services passes through to the bottom line on our income statement and becomes available to reinvest in capital equipment and our staff and employees. And so when we can maximize the use of the services we have as a community, it really is part of that virtuous cycle of then being able to invest in new services and replacing equipment. Not that the other parts aren't important, but from a financial side, that is really driving the success that will create good things in the future. So at a really high level, we've settled on some ways that we're going to measure the board's objective. The numbers here are less important for the moment. The tall bar that stays consistent across the top is really the estimated population of the service area, about 30,000 people. And the bar at the bottom is the number of people who we can attribute to a primary care provider. So who is chosen to get their primary care services through someone that is at Southwest Health. And this will be a measure for us over a long period of time that will help demonstrate internally to us and to the community that more people are gaining access to primary care. We wouldn't expect our hospital to be taking care of all 30,000. There's other primary care providers in the community, and our desire is not to be competitive in a way that we're pushing other people out, but we know that there's many people that are not accessing a primary care provider today for one reason or another, and we want to do our part to increase that, and this is one way that we can visibly see that happening internally. The other interesting thing is because we've created an attribution model, in the future we're going to be able to start measuring some quality pieces for patient populations that we serve. And so this is also a foundation around how we think about quality and access to care. When we think about access to emergency care, there's a couple of ways that we're looking at it. When somebody presents to the emergency department, most of the time they don't leave without being seen or treated. There are reasons why people may present and leave, and there's a national standard that says that should be less than 2% of the people that present to an emergency department. And so we're measuring when somebody shows up, do they leave without being seen or are they treated? And you can see looking across here, with the exception of 1 or 2 months, almost every month, month after month, we're about half of that national average. So we have a high degree of confidence that when somebody presents in our emergency room that they're going to have access and going to be seen and treated. The other way we're thinking about access to care in an urgent or emergent situation is oftentimes if somebody does present and there's a real illness that is going to take more than just a visit and discharge from the emergency room, they may need to spend the night in a hospital somewhere. Some of the time we may not have all of the capacity to care for whatever that person's needs are, and we may be transferring the patient out. And in a lot of cases we can help care for the patient here in our walls. And again, we want to help people get care close to their home, and part of having access to urgent and emergent services is having the bed capacity and the ability to treat somebody here. So the other thing we're starting to measure more closely is when a patient is in the emergency room and they are going to be admitted to a hospital, are they admitted to our hospital or are they transferred out somewhere else? And so you can see over time what our transfer rates are, our admission rates, and again, something that we're going to be looking at. And it helps us as we start to dig down. We're actually doing chart reviews on every patient that's transferred out so that we can start to gain an understanding of, is there equipment that if we had, we could have taken care of that patient? Is there medical expertise that if we would have had in the hospital at that time that we don't, would we be able to have helped care for that patient? And so it really, that review of transfers out is helping us think about where we need to make future investments so that we might have been able to keep that patient in our community in the future. Similar to 2024, where I showed you how we were planning for growth, this is what we're planning for 2025. And I imagine you do your financial planning early. We do ours almost 6 months in advance. And so when we put our budget and plan together, this will give you an idea of the area where we expected growth for the year. And again, you can see it ranging from some specialty visits on one end all the way down to we expected patients that come in and just are observed for a period of time to decline. And most areas of the hospital you see, we planned and expected for growth. I'm going to skip ahead, and this is what we've actually accomplished through the end of May. And you can see that even relative to 2024, this is growth on top of growth. And in most areas of the hospital at the beginning of this year, we have even been busier than what we planned for. And so that adjusted patient days number that I highlighted, where when we add all the activity together and measure it in one number, where it was equal in 2024 to what we planned, through April of this year, that is almost double what we planned. So we planned for about a 4% growth, and we've seen 7% growth over the year. To translate this, I don't think I have a slide on it, but to give you a sense of the tremendous impact that this is having when community members choose to get care in our local hospital, our net income through April of this year exceeded our net income of all of 2024. So the choice that people are making to come get care at Southwest Health System is really the driver that's providing financial stability to healthcare in this community more than anything else at this moment in time. I want to talk a little bit about, from a financial plan, what we expected to happen, and this will then tie into some of the financial headwinds and challenges. So we expect to collect about $83 million in total, primarily from services that patients receive in our hospital. We plan for a little bit of philanthropic giving, about $250,000 raised through our foundation, and we conservatively expect that there will be about $2 million passed through in sales tax from the hospital district to Southwest Health System. Of those dollars that we collect on fees for services, the direct fee portion from Medicaid represents for us about 17% of all the cash we expect to collect. You may have been reading about some of the provider taxes, state-directed payments, or other things that the Senate is looking at currently. Those aren't included in that 17 or 18%. When you add some of the other mechanisms that Medicaid funds Southwest Health System, that percentage actually goes up to about 24 to 25% of all the cash we expect to have. The net benefit of those state funds that go to the federal government are matched at the federal level in return. For us, the net positive impact of that is about $9 million this year. So the conversations that are happening currently in the Senate around what things to fund or not fund in a Medicaid program are very material to how we operate our hospital today. Here's how we plan to use that money this year. So about $76 million of that we expect to spend on just day-to-day operations, employee wages, supplies, utilities, the things that we all spend on our business or running our homes. We have some capital purchases that we've made in the past that are through loans, and so we've got about $750,000 that we're going to retire in debt associated with previous purchases. We've saved some of the cash that we're going to generate this year for that conversion in electronic health records. We also saved cash last year for that conversion. So we've internally funded ourselves to make that conversion when the time's right. We expect to pay back about $2 million on our bond debt, and then you'll see we've got a little over $1 million that we plan to spend in capital equipment. So going from $50,000 of spend last year to over $1 million this year starts to eat away at some of those needs in terms of equipment replacement. Lastly, the piece that I'll highlight from a strategic planning side that is starting to take hold this year already, and really moving towards how do we help people achieve their health and how do we impact care outside of the time when somebody's directly in our walls. So we've now partnered with a group called the Community Care Alliance. It's a consortium of hospitals and healthcare providers in Western Colorado based out of Grand Junction. And we're working with them on a regional care collaborative that is staffed by nurses who work remotely, so not in our walls, but we have a couple of nurses that are now dedicated to care management for patients that have Medicare Part A or B in our community. And so if a patient comes into our emergency room or is admitted to our hospital and discharged, and they may need some help making sure that they understand their discharge orders, they have their follow-up care scheduled, they know why they're taking their medications, and need to be reminded of some of those things to monitor side effects. In the time between when they're discharged from the hospital and they see their primary care physician, there's a nurse that gets connected with that patient and can help hold their hand in that period of time to make sure that they are going to have their optimal health at the time of discharge, reduce the chance that they're going to have to come back into the hospital or come into the emergency room in that interim time before they see their primary care provider. The second place where this group is able to intervene, again, with Medicare patients is those that have multiple chronic conditions. So either a patient or one of our providers can help the patient get connected with a nurse who's working remotely to help, again, manage the patient in between what may be their regular visits with their primary care provider. So checking in to make sure that they're adhering to their medications. If they change medications, to monitor and make sure that there may not be side effects, that the patient may not report readily. And so that way you get adherence to the medication that they have. If they are having maybe some worsening of symptoms or changes, that they have someone they can reach out to and say, do I need to help schedule an appointment? And the nurses that are a part of the team, we're really intentional. We don't want them inside of our walls working because they would get distracted with our day-to-day operations. So having them working remotely actually is a benefit because their focus is on the work of the patient who's not in our walls. And while they may not be physically in our walls, they're virtually in our walls. So that nurse care team has direct access into the patient's electronic chart and record. They're able to document all of the encounters that they're having with that patient, and they're able to see all of the same information that's recorded by their primary care physician in our chart. So this is one of our first steps in terms of starting to think about how we coordinate care for patients when they're not in our walls. The second place where we will be adding this is for our own employees. So right now we're looking at our own employee benefit structure, and we will be looking to embed this same service for our own employees as a part of their health plan. We plan to monitor that and see how that is working for our own employees. And later next year, we expect to be able to come to self-funded employers in our own community and talk with you about how you could embed that same service into your own employee benefit plans. Again, all with the goal of lowering healthcare costs and improving the quality of care for patients. All right, so some challenges ahead, things that may get in the way of all the good work that we're doing. To give you some context, over the last several years, the cost of healthcare has been rising, whether it's supplies, labor costs, and even today, the price of goods that we purchase is still outpacing inflation in the general economy for us as consumers. And in the state of Colorado, most hospitals don't have a sustainable operating margin. And generally speaking in hospitals, we think we need at least a 3 or 4% operating margin over a long horizon of time, multiple years, to be able to continue to replace the capital and equipment that is needed to care for patients. So the current environment coming out of the pandemic for the last several years, most hospitals in the state of Colorado have not been operating in a way where they're generating that type of a margin to continue to replace the equipment and facilities that are needed. And then if you look at the cost per discharge, so a patient comes into the hospital and they leave, how much money did we spend while that patient was in our walls? Again, on average over the last 5 or 6 years, that's gone up by approximately a third. So there's just, without any changes in the regulatory environment or what may be happening on a state or a federal level, just the nature of the economy of healthcare is presenting challenges to the cost that it takes to care for somebody and what that means in terms of what's left over to reinvest in hospitals. I touched on Medicaid and the dependency of Medicaid funding for the hospital. And we can think about the individual person, and if somebody loses their benefit, like what does that mean on an individual level? Collectively, if we have fewer individuals that are receiving a benefit through Medicaid, it doesn't mean that their healthcare needs went away. And our costs are generally fixed. So most days when we wake up in the morning at the hospital at 12:01, we know that it's going to cost us somewhere in the neighborhood of $210,000 to $215,000 to operate the hospital until we close it at 11:59 that night, and the cycle repeats the next day. If we take care of one more patient or one less patient, generally speaking, that cost stays about the same. The variable supply costs, whether it's medications or IVs, are a very, very small part of what we do. And so if we see a substantial change in Medicaid funding, even if we didn't take care of the patient and we thought, okay, well, that's going to lower our cost because we saw fewer people, what we would have to spend to keep the hospital open wouldn't change very much. A few less medications, a few less IV bags, but the overall cost of the hospital would remain largely the same. And what you can see on here is that very consistently over the last 6 or 7 years, somewhere between 20 and 30% of what we collect in cash comes from the Medicaid program. This year we forecasted it to be a little bit lower on a percentage basis. Last year it was almost $1 and $3 that came in were from Medicaid. And those are all our audited financials. So this community is very dependent on that program being funded adequately. Why is that important for the community beyond the healthcare delivery? So we're also a relatively large employer in the community. Looking at some of the data from Region 9, about when you look at payroll and how much we all pay in for employee wages, the hospital alone is responsible for just over 7% of the wages that are paid in Montezuma County. So if the hospital contracts or shrinks or grows, the wages that are paid to people in the community that get recirculated and respent change in one direction or another. And we tend to have higher paying jobs. So again, looking at data from Region 9 and other places, there's some published data on what a livable wage is. Whether we agree that that's livable or not, the published data for Cortez as a livable wage is about $33,000 for a single individual, not married, no children. The median household income for Cortez is about $51,000. Household income is all the members of the household. I believe it's age 15 and up. So in our household, both my wife and I work. We have an 18-year-old who works. It would be the combination of all three of us that would be that middle $51,000 if we were the median. And the median wage that Southwest Health System pays for a single person, not for the household, is just over $60,000. So not only on a large scale are we a large contributor to payroll wages in the community, we're also a large contributor in terms of higher wage jobs for the community. And so as healthcare goes in many rural communities, the rest of the economy can follow in some way, shape, or form. So I've shared this before as I kind of wrap up and take questions. I think right now we're experiencing the positive impacts of a lot of people working together. I've appreciated the relationship with your city manager, with our county manager, with some of the nonprofit communities and others. You've all welcomed me with open arms over the last few years, but really this community has dug in to preserve great health care, and it shows both in the quality of care that we're providing and the stabilization of the hospital. And it's not just in dollars and cents. These are a variety of clippings out of the local press. We've developed a really good rapport with the Journal and their local reporters, and they've been wonderful in highlighting a lot of the great work that's happened over the last few years. So happy to take some questions. Again, appreciate your time and support of the hospital and the community.
Thank you. Any questions for?
First of all, Joe, thanks for being here. I just have a really quick question. I don't know if the data exists, but I was just curious about how we compare in terms of grant awards to other rural hospitals in Colorado.
Great question. I don't know the answer. I'm guessing the data exists somewhere, and what I would say is from year to year, it's really highly variable. And so some of the largest awards have come from like Department of Local Affairs, DOLA, or congressionally directed spending requests. And those tend to be, like in a single year, can be millions of dollars at one time. From a philanthropic side, just polling some of my peers, so I don't have data, but I was curious, like what's the philanthropic, giving effort of our community relative to similar sized communities? And I'll say generally what I hear for similar sized communities in Western Colorado is anywhere from 1 to 3 on a high end, maybe $500,000 a year. That's when you pull like Aspen and Vail and those places out. But if you were to look at like Craig Steamboat, those size communities, Delta, you're going to see a couple $100,000 a year of philanthropic giving. And, we're on the lower end of that, but the last 2 years we've been pushing our way up. Yep.
Well, thank you so much for being here. We really appreciate the update to the hospital. It's a vital part of our community, and really just commend you for all the great work you've done since being leading that organization. So thank you.
Thanks, Mayor. And again, thanks for all your support and the opportunity to share with you how we're doing.
Right, and we'd love to see you regularly, so, if that's not established already.
Well, you let Drew and I know what regularly looks like. I'm happy to be available, and you don't have to answer tonight.
Every twice a year? I don't know.
I'll stay in touch with Drew, and I'll make myself available.
Okay.
Thank you.
All right, we'll move on to B on our agenda. Council will consider going into an executive session.
I move that City Council go into executive session for the sole purpose of discussing a personnel matter as authorized by C.R.S. Section 24-6, 402 F1. Specifically, the purpose of the executive session will be to conduct an annual performance review for Patrick Coleman, the Cortez City Attorney, and to discuss possible amendments to Mr. Coleman's employment agreement. Mr. Coleman has not requested that this executive session occur in an open meeting.
Second.
Motion made by Dobry and seconded by Lewis.
Aye.
Aye.
Yes.
Aye.
Aye.
Aye. All right, we'll be back. Do we have Matt? I don't know, should I call Matt? Because like, this meeting isn't over. I still have something to read, and then we gotta go to the next agenda item, like, this isn't over. Matt. 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 All right, it is still June 10th, 2025, and the time is 7:28 p.m. The executive session has concluded, and the council is reconvened into open session. Those persons participating in the executive session were myself, Mayor Rachel Medina, Mayor Pro Tem Dennis Spruill, and council members Robert Dobry, Matthew Kiefhofer, April Randall, and Bill Lewis. City Manager Drew Sanders and City Attorney Patrick Coleman were present for the start of the executive session, and Patrick Coleman rejoined the executive session at 6:58 p.m. No adoption of any proposed policy, position, resolution, regulation, rule, or formal action occurred during the executive session. If any member of council or a member of the public believes that the subject matter of the executive session was not statutorily authorized, or that the discussion occurred in executive session that strayed from the announced subject matter, please speak up now. Seeing none, we will proceed to the next item on our agenda. We have C on our workshop agenda, council general discussion. Do we have any topics council would like to bring up? All right, seeing none, we will end the work session and we will start our regular meeting in 10 minutes. Thank you.